Good morning, everybody. I'm happy that Dr. Oswald is presenting the important topic of hereditary colorectal cancer. Dr. Oswald is a 6-year resident, and the topic is pretty complex, but also very fascinating, and is probably becoming more and more important in the future, so it is quite reasonable to deal with it now. I'm delighted that Professor Gubler is here also, who is supporting us today, but also during daily life with diagnosing and surveying these patients. Thank you very much.
Thank you very much for the introduction, and welcome everybody. I'm going to talk about the hereditary colorectal cancer, but I would like to start with a short introduction. Colorectal cancer is the second most common cancer in female and the third most common cancer in male. Most of them are sporadic, around 70%, and in sporadic colorectal cancer, you do not have a family history. It's accumulation of somatic mutations that lead to the cancer. And there is a second group, the so-called familial CRC. Affected patients, they do have a family history for colorectal cancer, but there's no specific genetic cause identified or not yet identified. Having an affected first-degree relative increases the risk by the factor of 2. And having more than one relative affected, or if the first-degree relative is affected and diagnosed under the age of 50, the risk increases even more. And then there's the third group, this hereditary colorectal cancer group. It's only 5% of all colorectal cancer, but here you do have a specific germline mutation, and this germline mutation can be inherited or due to a de novo mutation. And it's important to know if it's due to a de novo mutation, this mutation occurs spontaneously in the ovum, the zygote, or the sperm, and you do not have a family history of colorectal cancer. But this mutation can be passed on to the next generation. So these are the syndromes I'd like to talk about today. You can divide them into the polyposis syndromes and the non-polyposis syndromes. And these polyposis syndromes can be further divided into adenomatous polyposis syndromes and hematomatous polyposis syndromes. I like to start on the left side with the familial adenomatous polyposis and the attenuated FAP. The familial adenomatosis polyposis is an autosomal dominant inheritance. It's a germline mutation in the adenomatous polyposis coli, the APC gene. I'm sure you've all heard about this gene. It's not only important in the FAP, it's also important in sporadic cancer. You can find the APC mutation in around 80% of the sporadic cancers. More than 1,000 different mutations of the APC gene are associated with the FAP. And 30% of FAP cases are due to de novo APC mutations. It's quite rare, it's less than 1% of all colorectal cancers. What you find in a FAP is a massive polyposis, more than 100 adenomatous colorectal polyps, and it can be up to several thousand of polyps in the complete colon and the rectum. The diffuse polyposis develops in the second or third decade of life, and the onset of the polyps is always in the left colon. The lifetime risk for colorectal cancer is 100%. There's a complete penetrance. And the average age at cancer diagnosis is very young. It's only 39 years. But it's important to mention that these adenomas in the FAP, they do not have an intrinsically higher malignant potential than normal adenomas. It's just the vast amount of polyps and the young onset of the polyposis that sooner or later one of these adenomas will develop into a cancer. There are some additional cancer sites. Every patient has gastric polyps, but the majority of these lesions are benign fundicular polyps. A gastric adenoma is quite rare. It's more common to have a duodenal adenoma, around 90%, or a duodenal carcinoma, 5% of all the patients. Or a desmoid tumor in around 30%, especially abdominal desmoid tumors. And thyroid cancer in around 2%, typically papillary thyroid cancer, and mostly in women. There's a female to male ratio of 19:1. And there are other tumors associated with the FAP, such as the medulloblastomas, gliomas, epidermocysts, lipomas, osteomas, fibromas, or adrenal adenomas. The surveillance in the FAP should start at a very early age. You should do annual sigmoidoscopies from the age of 10 on. You can start with a sigmoidoscopy because of the onset is always in the left side of the colon. But if there's a presence of polyps, you do have to complete the colonoscopy. you do have to perform upper gastrointestinal endoscopies from the age of 25 on. Having a duodenal adenoma or carcinoma before the age of 30 is very rare. And the interval is depending on the Spiegelman criteria. These are the Spiegelman criteria. It's the number of the polyps, the polyp size, histology, and the grade of dysplasia. And all these points can stage it into a stage 0 up to a stage 4. If you have a stage 0, it's usually enough to perform an upper endoscopy every 3 years. If you have a higher stage, you should shorten the interval. And if you have a stage 4, you have to talk about prophylactic operation with the patient. And then, as we've seen, only for female, you should do an annual thyroid ultrasound from the age of 15. So because of the early onset and the complete penetrance, you usually should perform a prophylactic surgery in the FAP patients. What you have to do, it's because of the complete colonies involved and the rectum, you do have to do a proctocolectomy with ilioanal pouch anastomosis, as shown in this picture. As a surveillance, you do have to perform a yearly pouchoscopy. And here there's a picture of a specimen. Again, you see this massive polyposis. The next syndrome is the attenuated familial adenomatous polyposis. It's an attenuated, so a mild form of the FAP. It's also autosomal dominant inheritance, and it's a germline mutation of the APC gene. But these APC gene mutations, they differ from those detected in the classic FAP patients. And it's even more rare, also less than 1% of all colorectal cancers. It's typically an oligopolyposis. It's 10 to 99 adenomatous colorectal polyps, and the onset of the polyps that's different to the FAP is often in the right colon. The rectum is usually spared, and the adenomas and cancer occur 10 to 20 years later than typical FAP, and the extraintestinal malignancies are less frequent. So this difference makes the surveillance a little different to the FAP. You do have to perform colonoscopies every 1 to 3 years from the age of 15 on, depending on the amount of the polyps. The upper gastrointestinal endoscopy from the age of 25, and the interval is also depending on the Spiegelman criteria. Because the rectum is usually spared in the AFAP, you don't have to do a proctocolectomy. A colectomy with the iliorectal anastomosis is enough, as shown in this picture here. As a surveillance, you do have to do a yearly rectoscopy, and if you find polyps in the rectum, or if the rectum isn't spared at the beginning, you should do a proctocolectomy with ilioanal pouch anastomosis, such as in the FAP. In a little subgroup, it might be possible to only do the endoscopic surveillance, that they do not need surgery. But it's definitely such a little group. Most of the patients do need surgery at one point. So we've talked about the first two polyposis syndromes. The next is the MUTYH-associated polyposis. And the most important thing, it's an autosomal recessive inheritance. It's the only autosomal recessive inheritance in this syndrome. It's a germline mutation in the MUTYH gene, and it's estimated that 1 to 2% of the general population is monoallelic. And the monoallelic patient only has a slightly elevated chance for a colorectal cancer. It's an oligopolyposis with 10 to 100 colorectal polyps, and the lifetime risk for a colorectal cancer is high, 70 to 80%. The problem here is because of the recessive inheritance, you usually do not have a family history for colorectal cancer. That's why a lot of patients already have colorectal cancer at first admission. And the mean age for colorectal cancer is 45 to 60 years. There are increased risk for developing cancer of the duodenum, the ovaries, the bladder, the thyroid, and the skin. The surveillance of the MAP is quite similar to the AFAP. You do have to perform colonoscopies every 1 to 2 years from the age of 20 on, and upper gastrointestinal endoscopies from the age of 30 to 35 on. The interval is also depending on the Spiegelman criteria. The surveillance is unclear concerning the ovaries, bladder, thyroid, or skin. There is no clear recommendation how to do that. So surgery in the MAP, also the same as for the AFAP, a colectomy with iliorectal anastomosis, and for surveillance, a yearly rectoscopy, and if the rectum isn't spared, a proctocolectomy with ilioanal pouch anastomosis. So we talked about this adenomatous polyposis syndrome. Then there are hematomatous polyposis syndromes. There are a few of them, but just like to talk quickly about the Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is an autosomal dominant inheritance. It's a germline mutation in the STK11 gene. That's a tumor suppressor gene. And 10 to 20% are due to a de novo mutation. The penetrance is very high. It's over 90% by the age of 30. There are two characteristic manifestations for the Peutz-Jeghers syndrome. It's multiple hematomous gastrointestinal polyps and pigmented mucocutaneous macules. These macules are mostly on the lips, in or around the mouth, and on the skin of the hand and the feet. They do fade away during life. The lifetime risk for a malignant tumor is up to 90%, and the average age of developing a malignancy is 42 years. There are mostly gastrointestinal cancers such as colorectal cancer, pancreas, stomach or small bowel cancer. And for female patients, there is an increased risk for extraintestinal cancers such as breast, ovary, and cervix. So we've heard now about these polyposis syndromes, and as you've seen, all these syndromes do have a more or less distinctive phenotype that helps to make the diagnosis, or at least think at one of these polyposis syndromes. For the HMPCC, the hereditary non-polyposis cancer, or so-called Lynch syndrome, that's completely different. There's no specific phenotype that would suspect a Lynch syndrome. And that is why there are some criteria and guidelines that should help to detect families or individuals at risk for a Lynch syndrome. There's the Amsterdam 2 criteria, it's the 3-to-1 rule, 3 or more relatives, 2 or more successive generation, and at least one patient diagnosed before the age of 50. That should help to identify a family at risk for Lynch syndrome. The Bethesda guidelines is to identify a single individual with a colorectal cancer for risk at a Lynch syndrome. It's like a colorectal cancer before the age of 50 or synchronous or metachronous colorectal cancers. The problem is that the overall sensitivity and specificity is quite low. With only these criteria and guidelines, you could miss a lot of patients with Lynch syndrome. That's why nowadays it's recommended to perform routine testing for microsatellite instability for patients with a colorectal cancer. And microsatellite instability, that's the underlying problem at the Lynch syndrome. I'm going to talk about that now. So there are two major pathways to develop a colorectal cancer. It's the chromosomal instability pathway, the SIN pathway, and the microsatellite instability pathway, the MSI pathway. Mostly 85% are due to the SIN pathway, only 15% due to the microsatellite instability pathway. The SIN pathway, that's the typical adenoma carcinoma sequence. I'm sure you all have heard of that. And that leads to a microsatellite stable colorectal cancer. In the MSI pathway, there's at least inactivation of one of the 4 mismatch repair proteins, the MLH1, MSH2, PMS2, and MSH6. These mismatch repair proteins are responsible for correcting nucleotide base mispairings that occur during the DNA replication. And these mispairings most commonly occur in repetitive short sequences of 2 to 6 nucleotides. And these short sequences are called microsatellites. And if there's a defect in these mismatch repair proteins, it leads to a fast accumulation of genetic error at these microsatellites. A microsatellite instability, the definition is the inability of mismatch repair proteins to fix genetic errors at the microsatellite. And a mutation here leads to a microsatellite unstable colorectal cancer. But not every microsatellite unstable colorectal cancer is a Lynch syndrome. There are, again, 2 pathways. It's the mutational inactivation of these mismatch repair proteins. It's a germline mutation, and with a germline mutation that leads to a Lynch syndrome or HMPCC. But there's another way, that's the epigenetic inactivation. And as the name says, epigenetic, it's above the level of the genes. It's a local event in a tumor. And this is mostly a promoter hypermethylation that leads to an inactivation of one of these 4 mismatch repair proteins. That leads to a sporadic microsatellite unstable colorectal cancer. That's what you see on this slide. Again, 85% are microsatellite stable, 15% microsatellite unstable. Most of them are sporadic. only overall 3% are due to a Lynch syndrome, so due to a germline mutation. But that's enough for the genetics. I'm going to talk about the Lynch syndrome. It's the most common cause of an inherited colorectal cancer and probably the most common form of a predisposition to cancer. The lifetime risk for colorectal cancer is 60 to 70% versus the normal population around 5.5%. And the mean age of diagnosis is 44 years versus 69 years in a sporadic colorectal cancer. There are several additional cancer sites. The most important is the endometrial cancer. 40 to 60% of the female patients develop endometrial cancer. And as you see on this slide, it's different which kind of mismatch repair protein is mutated. There are other additional cancer sites such as the small intestine, hepatobiliary, pancreatic, gastric, ovarian, prostate or bladder cancers. The penetrance in the HMPCC is gene-dependent and age-related, and as you've seen, not every single mutation has the same risk for an additional tumor. The expressivity is very variable, and important to mention that the risk of a metachronous carcinoma is up to 16% in only 10 years. So the surveillance in HMPCC should be started early with an annual colonoscopy from the age of 25 on and the upper gastrointestinal endoscopy every 1 to 3 years from the age of 35. And for the female, annual gynecological examination, pelvic ultrasound, tumor markers and aspirational biopsy. So now, important point for surgeons, what kind of surgery do we do in HNPCC? We already know there's a risk of a metachronous carcinoma, 60% in 10 years. So what do we do? We might do as in the FAP, proctocolectomy, a prophylactic proctocolectomy with ileoanal pouch anastomosis, or do we just wait till the cancer occurs and do an oncological resection, maybe a hemicolectomy, or something in between, like for the AFAP, a total colectomy with ileorectal anastomosis. But to decide, we do need some more information. There are some specialties for microsatellite unstable colorectal cancer, not only for the Lynch syndrome, also for the sporadic cancers. They have a significantly lower rate of positive lymph nodes, a significantly lower rate of distant metastasis, and a lower prevalence of microsatellite instability and metastasized diseases. So that leads us to a stage-dependent distribution. In stage 2 colorectal carcinoma, it's up to 22.5% with a microsatellite instability. In a stage 4 carcinoma, it's only 3.5%. And that gives us the implication of a better prognosis. So now, we do know we have a high risk of metachronous cancer, but we do have a better prognosis for this single microsatellite unstable cancer compared to a microsatellite stable cancer. That's why the recommendation is to only do an oncological resection, and especially no prophylactic resection in HMPCC. That's different for the endometrial or ovarian cancer. We know that's the second most common cancer, and the mean age of diagnosis is around 50 years, and it's gene-dependent. The risk of endometrial carcinoma or ovarian carcinoma is reduced by prophylactic surgery. And that's why it's recommended to do a prophylactic salpingo-oophorectomy and hysterectomy for every female patient older than 35 years with finished family planning or for every postmenopausal woman. So now, after surgery, you might need an adjuvant therapy, and there are some specialties for microsatellite instability as well. It's known that 5-FU is ineffective in a stage 2 colorectal carcinoma with microsatellite instability. So there's no chemotherapy due to the better prognosis, as we've seen, and due to this chemoresistance of the 5-FU. It's different in stage 3 or 4 diseases. It's known that oxaliplatin has an effect, and especially in combination with 5-FU, such as in the FOLFOX regimen. That's why it is recommended for the higher stages. And there's one other drug I would like to mention here. This microsatellite unstable colorectal cancer are unstable and of hypermutational nature. They do have a high expression of checkpoint proteins, such as the PD-1 and the PD-L1. And they do show a good response to immune therapy with PD-L1 or PD-1 blockade in metastatic diseases. These are the so-called checkpoint inhibitors, a new kind of drug. Another important thing in Lynch syndrome is the chemo prevention. I'd like to show you this study. It's the CAP2 study that was published last year in The Lancet. It's a double-blinded, randomized, placebo-controlled trial, a multi-center study, 43 international centers worldwide, and including 861 patients. They are all proven carriers of a pathological mismatch repair mutation. Half of the patients took 600 milligrams of aspirin per day for 2 years, and the control group took a placebo. And these are the results of that study that were published last year. You see in the upper 2 graphs, that's the cumulative incidence for the colorectal cancer. On the left side is the intention to treat analysis, on the right side is the per protocol analysis, and you see a significant reduction for colorectal cancer. You have on the right side the per protocol analysis, you have a hazard ratio of 0.56 and the p-value of 0.019, so a robust reduction. In the lower 2 graphs, that's the cumulative incidence for all Lynch syndrome cancer, not only for the colorectal cancer. Left-sided also the intention to treat analysis, and the right side the per protocol analysis. And we do have a significant reduction. It's not as impressive as only for the colorectal cancer, but nevertheless, you do have a significant reduction here. Because of that study, there are several guidelines. For example, the National Comprehensive Cancer Network, in their guidelines in 2020, they write to consider aspirin for chemo prevention. The British Society of Gastroenterology, they do write to consider 150 milligram aspirin in the context of Lynch syndrome with a dose of 300 milligrams for a patient with a BMI over than 25. And the European Society of Proctology, they recommend a minimum of 75 to 100 milligrams of aspirin, and they increase those with patients with a higher BMI. As you see here, we do have the recommendation for aspirin intake as a chemo prevention, but we have no idea what would be the best dose. At the moment, there's an ongoing study, the CAP3 study, that compares the different dosages of aspirin as a chemo prevention in Lynch syndrome. Problem is we're going to have to wait around 10 years to have the definitive result. It's going to be interesting which kind of dose is the best. So that's what we've talked about, all these polyposis syndromes, and to come to a conclusion, the hereditary tumors are rare. It's only 5% of all colorectal diseases, but they are probably underestimated. And there's a major impact for every single patient, as you see on this slide, especially for the FAP patient with this complete penetrance, as well for the HMPCC if you compare it to the general population. So early diagnosis and the adequate surveillance are of the utmost importance for these patients. That's why here in Zurich, we do have the initiative for the hereditary tumor diseases. It's an interdisciplinary group, and the aim and purpose is to have a comprehensive standardized recording of suspected cases, a standardized diagnostic algorithm for the diagnosis, and a standardized implementation of follow-up and surveillance. We do it for all patients with a gastrointestinal tumor. We do this routine testing, and we come together every 6 weeks to talk about these patients and these cases. And with that, I'd like to end, and thank you very much for your attention.
Thank you very much, Dennis. Excellent overview, very nice presentation, very scholarly. And you've managed to press this highly complex topic into 24 minutes, which is recommendable. Are there any questions from the audience? So I may just start off by asking you a question. And I think that's a scenario that we encounter every now and then. A patient coming into your office telling you that his brother has been diagnosed with colorectal cancer at age 48. So what do I need to do? Do I need to undergo genetic testing? Do I need to have early colonoscopy? What do I need to do? My brother has just been diagnosed with colorectal cancer at an early age. It's a difficult to answer question.
Yeah, it's very difficult. I think it's important for the patient that was diagnosed if there is any genetic disease underlying the colorectal cancer. But if we have seen at the beginning, if it's only a familial predisposition, just have a risk that is twice as high as for the normal population. And they do recommend to do early colonoscopy, but no genetic testing if there's only one patient, one relative and if there's no genetic disease underlying.
I agree. There's different ways of how you could proceed here. One could be somewhat more vigilant or somewhat more risk-taking. What should we do with a young patient with colorectal cancer? How do we address his family?
I would do the whole family history first, and second, I would ask if there is tissue to check whether there is MSI instability. If you can find it there, to think about genetic counseling, but most important is to do a colonoscopy minus 10 years before the cancer of the brother in this case. But one patient in the whole family, it's not enough to do a genetic testing. But I would ask for the tissue in the index patient, and colonoscopy minus 10 years.
Colonoscopy minus 10 years. Sometimes we see that the story becomes more and more complicated, and Caroline Horisberger has initiated a meeting in which we discuss more complex cases. But so, Caroline, what do you consider to be cases that need to be discussed? When do we have a situation where we cannot just counsel the patients to have MSI testing and be done with it? Sometimes we need to have a closer look. Sometimes we need to consider whether we do genetic testing or not. What are the cases where we need to identify those patients at risk, where we need to do more than just the usual?
Thank you very much for the question. Thank you for the comprehensive talk, and that Professor Gubler is here, because I think, as well as they are very much interesting and extremely fascinating diseases, but beyond knowing a specific disease, it's what you said, it's very important to identify patients who are at risk for maybe being carrier of a genetic disease. And the risks we do have are what we saw in the lectures. There are some pictures with a specific phenotype. So they are diagnosed by mostly Professor Gruber, or suspected diagnosed. And then there are those without a specific phenotype, the HNPCC, or there are more and more upcoming diseases also in the field of pancreatic cancer or breast cancer, and the interference with these. So whenever we have patients with a young age of a cancer, we mark them and we discuss them in the meeting if we should go first a talk with the genetic specialist and then maybe proceed with a genetic analysis, or maybe, as Professor Gubler said, if there is some signs in the tissue with and whole genome analysis we do sometimes to see if there is a specific mutation which can lead us to a suspicion of a disease or being only a carrier of something.
What I'm just a little worried about is, even though familial colorectal cancers are a minority, colorectal cancer is still a very frequent disease. So I'm a little worried about the number of patients that we just do not identify. So how many people are walking around with a familial colorectal cancer that is just about to become apparent, where we may have a chance to detect them early, but we just don't, because we don't know the key facts, or we just miss the key points in detecting them early?
It's a very difficult question. I cannot answer it in absolute figures, but in percentage, and it's not that high as you mentioned. But my key is always to the family history at the end. We do not ask the patient about the whole family history, not only the colorectal cancer, all other cancers, because as we know now, it's a more difficult pattern of phenotypes to get the familial cancers. But the absolute figures I cannot give you. Eventually Caroline can do that.
Yes, I calculated it once, just because of the numbers. We know the risk of being a carrier of a HNPCC. So there must more or less be 16,000 carriers of a HNPCC disease in Switzerland. So there must be a lot. And we surely do not know all of them, but I don't know what percentage we know.
That's the one figure that I'm personally a little bit worried about. And we sometimes do see colorectal cancers developing in patients where in the aftermath we go back and we clearly recognize, that there have been signs in their previous life where we could have started investigations earlier. Maybe one specific point also to mention is, you have nicely shown us the different types of operations that we can do for example, attenuated FAP. Sometimes these are limited resections. And just one point that I may want to stress out is that whenever we do a limited resection and we leave part of the colon and rectum behind, we are really in a position where we need to ensure adequate follow-up in these patients. Especially the attenuated FAP. We leave the rectum behind in a young patient. Did this patient really have attenuated FAP, or was it just a classic FAP waiting to become diagnosed at a later age? We have seen more than one patient who had an ileorectal anastomosis and developed a rectal cancer, stage 4, within a few years after the diagnosis of his AFAP. So I'm a little bit worried about that. And especially those who undergo surveillance endoscopies for 1, 2, 3, 4, 5 years, but then they're in their lives, they may start a family, they have other things on their minds, and they just skip their endoscopies. Maybe, Christoph, you want to comment on that?
Yeah, it's a usual problem. The surveillance work for 5 years, 7 years, and then they skip it. But that's why we have a recall system for all these patients, even with a pouch. Just do it once a year. But it's very difficult to keep them on, because if they do operate them at early age, you miss them after 10, 15 years.
I would like to emphasize as well the surveillance and the recognizing of the patient with hereditary disease, because our treatment, the oncological treatment, is so much better nowadays than it was 30 years ago. So we not only make people survive the first cancer, but we see more and more patients with the second, third, or even fourth cancer. And so we really have to adhere them to the surveillance and need specialized groups who know what they have to survey, so like Professor Gubler, and to discuss, because it's really important that the people do not only survive the first cancer, but to have a complete life.
So surveillance is key. Any last question from the audience, residents, students? No one? If not, thank you very much, Dennis. Excellent talk.